So our first presentation is focused, in my view, on one of the most important papers that we've published in the Journal of Marketing in a very long time. Professors Yixing, Chen, Hari Sridhar from the Texas A&M University, and Vikas Mittal from Rice University join us to talk about their National Institute of Health sponsored research developing and deploying personalized outreach strategies to improve cancer screening. Welcome, Yixing, Hari, and Vikas. We look forward to learning more about this important paper.
Thank you for hosting this, Chris.
This is Hari here. Thank you, Chris, and thank you to the Journal of Marketing.
This is Vikas. Chris, thank you so much for this opportunity. We're very delighted to share our research, and Yixing, please take it away.
Thank you, Vikas. This is Yixing here. First, I would like to thank Editor-in-Chief of Journal of Marketing, Chris, and Production Editor, TJ, for providing us a platform where we can share this research. This is a joint work by researchers across multiple disciplines from multiple universities. Today, my co-authors, Hari, Vikas, and I are very excited to share with you how cancer care institutions can use personalized cancer outreach program to save more lives and money. When you look at the websites of leading organizations in the cancer care space, there are so many examples of cancer outreach programs. For example, American Cancer Society worked with the NFL to jointly launch a campaign called Crucial Catch. The goal of all of these outreach programs is to convey the importance of cancer screening and intend to increase screening rates among at-risk patients. Apparently, organizations spend a lot of money and resources on outreach programs. However, they're not as effective as cancer screening rates are very low. If you look at this article from Los Angeles Times, it says that only 4.2% of at-risk patients for lung cancer in the United States get screened, even though cancer screening can reduce mortality rate for lung cancer by 20%. When you look at the spending from American Cancer Society, they spent $129 million on outreach itself in 2017, which is approximately 15% of its annual budget. We have a doctor in our team, and we speak with Dr. Amit Singhal for many, many times, and the doctors are also curious to know why this is the case. One of the reasons he proposed could be we're not using the right outreach strategies. And as we talk more and more about this, we realize there are two main challenges we're facing. First, we don't have a solution to quantify the return or to measure the return of outreach programs. Second, the current methodology does not allow us to personalize outreach efforts. We spent the past 2.5 years as a team to put together this study and try to address these challenges in 3 phases. In phase 1, we want to test the effectiveness of different outreach strategies. So we use a randomized field experiment where we randomly put some individuals in one group and some other individuals in different kinds of outreach conditions, try to test what's the average effectiveness of outreach strategies. But we do not stop here. We want to know more, that we know patients are so different in terms of their characteristics. And in phase 2, what we're trying to do is use the novel machine learning algorithm to take all the patient characteristics into account and to understand how Light Touch or Patient Navigator will work differently for each individual given their profile. In the third phase, when we take all of these 2 things together, when we revisit our original allocation, which is based on random assignment, now we can match each patient with the most suitable condition, and then we can show the implications of that personalization exercise. So what did we find? First, good news, we find outreach works really well. It can improve cancer screening rates by up to 24 percentage points. And second, we also find outreach effectiveness vary widely across patients. And third, personalization helps. It can improve return on outreach programs by 74%. Next, I'm going to walk you through each one of these phases. As I mentioned earlier, the goal of all these outreach programs is to encourage cancer screening rates. So the focal outcome of interest is whether or not a patient completed a screening. We're fortunate to have a 3-period field experiment So we're able to evaluate that outcome between 0 to 6 months, 6 to 12 months, and 12 to 18 months. And we randomly assigned 1,800 patients in one of the three conditions. A baseline condition where we do not have outreach offered. Patients go to their care providers and doctors provide recommendations at their discretion. A light touch group where we, on top of the visit-based screening, we have outreach letter demonstrating the risk of not coming for screening and the benefits of coming for screening. A patient navigator condition where on top of the visit-based screening and outreach letter, we have trained research staff to provide motivational education to alleviate mental barriers of patients related to the test. So what did we find? Do outreach programs work? If you look at this graph, if you focus on the y-axis, it refers to the percent of patients who completed the screening in each condition. Let's focus on the left panel first. So this 25% means 25% of 600 patients in the usual care group completed the screening. That is about 150 patients. What is that percentage for light touch? That's 45%. What is that percentage for patient navigator? That's 48%. So when you look at this graph, you might draw two conclusions. First, good news, outreach works tremendously. That if you focus on the light touch and patient navigator, they improve the percentage of screening rates dramatically. Second, you might also see 48% doesn't seem to be that large compared to 45%. So let's hold on for a second. Can we really conclude that patient navigator is simply a waste that we should do light touch to every single individual? That leads to the main goal of our phase 2. So let's focus on this graph for a minute. What I described earlier is compared to the usual care, a light touch can improve the screening probability for patients by 0.2 on average. But is that really true for each one of the individuals? Given we know that individuals are so different from each other in terms of their demographics, visit history, health status, and neighborhood characteristics. So we're very fortunate to have leveraged a novel machine learning algorithm called causal forest, where we take all the patient characteristics into account and break that 20% difference to each one of these individuals. So as you can see from this graph, it plots what's the probability lift for each individual if we do light touch to all of them. How does that probability look like? As you can see, it can be as low as 11% for some individuals, and it can be as high as 31% for some other individuals. And we found similar patterns. If you look at patient navigator, it can be as low as 12% for some individual, and can be as high as 37% for some other individuals. Then when you look at these two graphs, the natural next question you might want to ask is, who are these people? Right? Can we profile these people and to get a better understanding of who they are? So this is what this table can tell us. Basically, there are two key takeaways. First is these characteristics provide some baseline for us to personalize outreach efforts. In other words, these are the characteristics healthcare institutions can use to personalize outreach efforts. Second, the ideal condition for different patient persona may be different. For example, if I focus on the light touch group, people who are more responsive to light touch tend to be younger people, tend to be female, part of a minority group, and tend to be in better health condition, tend to have a richer visit history, and tend to have better access to healthcare system, and tend to live in a shorter, in the location where we have shorter commute time. An ideal persona for patient navigator seems to be older patients, female, part of a minority group, in better health condition, richer history, better access to healthcare system, and those neighborhoods who have higher income. So what's the point of doing all of this? Is now we can take all of these patient level differences into account and revisit our original allocation, which is based on random assignment. Now we can put each individual, we can imagine a world we can just put each individual in the ideal condition. So what are the implications of this exercise? First, we can see that average screening rates improved. So it used to be 38% out of 1,800 patients. Now it becomes 42% of 1,800 patients. That itself means we bring 72 more patients to get screened. So what could be the financial implications of that? it actually improved the return to the healthcare system from $2.1 million to $3.7 million. That is a 74% lift. So how does this 74% lift come from? On the one hand, you can think we bring more people coming for screening, so we generate health benefits associated with a concept called quality-adjusted life years. On the other hand, we simply save money because we're not targeting the wrong people using the wrong approach. So basically, this slide can conclude our main insight. It's also the title of our presentation, which is personalized cancer outreach can save both lives and money. And that's also the last slide of my presentation. I want to thank all of you for your time. I think we can take questions now. Thank you.
Thank you so much for these important insights, Yixing. So we now have time for questions from our listeners. If you'd like to ask a question, you can do so by typing it into the Q&A tab that you see on the side of your screen there. Not the studio chat tab again, but the Q&A tab is the place where you can type the questions. So let's go ahead and start with what I can imagine for many of the medical professionals or marketers involved in the healthcare world are thinking about these days, which is, of course, related to COVID-19. And so to what extent can you share the way in which your results might generalize to coronavirus testing, maybe even other types of cancer screening? I mean, medical testing in general, both delivering it, getting people to show up for it. So share with us in a broader sense what your results mean for people engaged in this type of activity within their healthcare institutions.
Thank you, Chris. Thank you for that great question. So here's how I think about this. So there are two ways we can extend this framework. First is other types of cancer screenings. So first of all, the framework, the broad idea of our framework is we test if some intervention, say outreach program or drug effectiveness, any kinds of marketing interventions. So we want to test whether or not it works. Then we take this effectiveness to different kinds of individuals, see how effective for each one of the individual. Then we can personalize the intervention accordingly. So based on this framework, it can be easily extended to other kinds of cancer screening. So the second is related to coronavirus. So I think what this tells us is what some of the methods, is there a methodology we can use to personalize any kinds of marketing interventions? So for coronavirus, one parallel example could be we're testing the drug effectiveness, or we're testing different kinds of prevention strategy, such as like self-quarantine, where should we go to see our doctors right now? So these interventions could have different effects for different kinds of patients given their characteristics, right? So this is actually a table I just brought from a recent paper. So we can see that there are clearly a very clear group of at-risk patients, and the strategy may have different effects on these at-risk patients versus other subpopulations.
Mm-hmm. And could you do the same thing if you had information about their likelihood of coming in for testing, for example? Because it's not just, I mean, obviously in the end we want to save their life, but we also know that the first step may be to get the testing. So could you also think about it, because I think that's the equivalent of your screening focus in the cancer paper, right?
Absolutely. This is Hari here, folks. Thanks, Chris, for the question. And I want to reiterate what Yixing said. What we have ultimately here as in terms of the problem is we have large populations, obviously a lot more in the case of the coronavirus, fewer in the case of cancer, that we want to bring in for screening. So that's the problem. What we want to do is to solve this problem that we bring them in for screening, but also do it in the most beneficial way from a financial standpoint, right? So you can think about the different elements of this approach. One element is the different outreach strategies or the ways to get people to come in for screening. The second element here is that each patient, like Yixing has on this slide, has fundamentally different characteristics due to their demographics or health history that makes them more or less likely to respond to different kinds of outreach. And then you have the third situation, which in this case is the government, but in cancer situations is the healthcare institutions in terms of how much money they have for each of these kinds of outreach strategies. What we've tried to do in this paper is to also provide a broad approach where you take the patients involved, the strategies involved, and the money involved, and ultimately understand the outreach effectiveness of each kind of strategy for each kind of patient. So you can match the patient to the best strategy that is likely to bring them in for screening, but also therefore save their life and hopefully also save money. So in the case of coronavirus, if you have 2 or 3 different outreach strategies, the idea will be to better understand which strategy is going to make which kind of patient come in the fastest for testing.
Could you share any other specifics in terms of the light touch and Navigator strategies that were used, just to more fully educate all of us on the specifics that you utilized there? And obviously, different types of information would be, would be of relevance to different types of screening activities or disease conditions, but what was it that actually went on within the outreach letter or within the phone calls? What kinds of things? You said, for example, motivational strategies to overcome some of the barriers that they might have. What was it that actually went on?
Yes. So let me go back to the slide and give one. So let me give you one example of motivational education. So I think one very key lesson we learned in this project is the importance of screening and importance of regular screening. So in the liver cancer space, where we're just not simply want people to come in once and then they're done. So actually, the medical community recommend a screening every 6 months. So in other words, we're hoping that people can develop that healthy habit if they're at-risk patients so they can come regularly. So one example in the motivational education would be some patients will say, I've already done this test once, so I don't have to come. So the trained research staff will tell them it's important to come for regular screening. So that will be part of the motivational education, just as one example. And another example could be if they worry about if they're going to find some test results that are they're not going to, the bad test results, so they're going to be scared. And the trained research staff will tell them that this is better than find it later. So we'll have corresponding strategy of communications to certain patients related to specific to their concerns. So those are 2 examples I would give in the third condition.
So this is Vikas, and I'll add to it. One way to think about this is patient navigators are trained staff members. And the best way to think about them is that they are, in some aspects, relationship managers, right? So one of the things that happens with something like cancer or some kind of surgery is patients, because of the type of conditions, patients often feel confused. They don't feel that they have anybody that they can talk to and have a relationship who can give them good advice. And navigators essentially play that role. Right. So patient navigation is extremely expensive, and that's why when in our research, if you can identify patients who could get the lift just through light touch and not have to go through patient navigation, that saves the hospital system tremendous amount of money. Right. But essentially, patient navigators are relationship managers who kind of get to know the patient. Patients kind of can confide in them. Patients can ask them anything, and they also proactively will reach out to patients and tell them, like, look, I know you feel scared, but this is how these things are done. And they have like a specific script, as Yixing was pointing out, to follow.
Wonderful. And so Jacqueline has written a question. She wanted, I'm not sure if it's this slide, she was asking about putting the slide back up that reports the percentage of how well the outreach worked. Maybe it's this slide here. So, Jacqueline, this information is also reported in detail in the paper, and we also will have kind of more of a called managerial summary of the results that report some of these details as well. Well, I'll keep this slide up, and let me just ask another question, because Yixing, when you were sharing the sort of the process that you went through, you described that you overlaid these personal patient, if you will, characteristics, their neighborhood, their income, their various characteristics, their gender, et cetera. So how do healthcare managers think about how to compile this set of characteristics? How do they develop those? What are some tips that you can give to them?
Yes. Actually, we have a section in the paper also talk about this in detail. The way we think about this is an iterative approach. So first, we will look at what health institutions have available. So, hospitals have electronic medical records, and they have a detailed information about patients. So that will be the starting point. Then we go and look at, what researchers study in the field, what are theoretically relevant variables there. So that's where we actually use the variable is whether or not a patient come for screening in a prior period. That is coming from the literature. And also in the process, we realize we have access to the location information of patients, so we're able to put together the neighborhood characteristics from sources such as American Community Survey or census data. So to put it in simple words is where we're taking a process where we go back and forth, and make it richer and richer, but at the same time, we also want to make sure these variables are relevant and also easily accessible for medical profession.
So I guess if a healthcare institution had the ability to collect any other deeper psychological characteristics of their patients through other means, those could also be relevant. So really whatever the healthcare institution has available to them or that they could collect through interviews or other surveys, they could use that to do this kind of algorithmic work, right?
Yes.
Yes, this is Hari here. I just want to reiterate what Yixing said and add a small point to it. One thing we try to do to make this approach, as practical and as applicable as possible is, we started with the electronic medical records that, these institutions already have, but we then went through an extensive, literature review of the medical literature, which is also in our paper, but tried to proxy variables that are readily available that tap into all the theoretical ideas that we know about from past literature that contribute to differences in effectiveness. So some variables that readily proxy some of the deeper theoretical mechanisms include, people's gender, their proximity to the hospital, and so on. So in some sense, we try to get the best of both worlds, try to use data that's readily accessible while making sure that, in fact, they have a deep-rooted premise in the theoretical literature on why people come in to screening.
Wonderful. Wonderful. So I think it's really unusual, but just outstanding that you're actually working with a physician. And so I'm just wondering if you might be willing to share about some of your other research experiences in working with physicians. I think it's an important collaboration. It's not one, like I said, that we see very often, but I think the field could really benefit from more of this. So I think it would be neat to hear what you guys are doing that might be helpful for people imagining what those collaborations might look like.
Sure. So this is Vikas, and I can speak to some of these things. So just as a starting point, we are now working with the same team of physicians, and what we are doing is we are extending this trial and collecting more data, and we are developing an algorithm to assign patients to the right bucket, and then calculate the cost of it even better. So that's the one thing we're doing in this regard. So then, one of the things that Hari and I are working on is a is some kind of research where we are able to see how internal processes within hospitals can help them to become better at becoming more innovative and creating innovation within the hospital systems, even when they don't have resources. In another project, we are looking at, again, working with doctors, how do doctors address ethical dilemmas that are not really medical questions, but ethical questions? Should you put a patient on hospice, or should you give them very expensive treatment where you need the family to get involved as well? And often these sort of tensions lead to a lot of animosity between patients and doctors and a lot of emotional distress. And you can use ethical committees to help resolve these dilemmas, and we try to look at what helps a doctor initially consult an ethics committee. I think the general philosophy under all of these papers is that people may think that marketing and healthcare are different fields, but within the healthcare field, when we work with physicians, they really appreciate the insights that marketing can bring, because at its core, marketing can help them address sort of how does an organization treat its customers, so the physician-customer relationship. How does an organization maximize its resources to get the right outcomes for the organization and the customer? And to our delight, physicians and hospital administrators have really welcomed this sort of a collaborative approach to it. And then I also feel that it's really important that journals in the marketing field have embraced this, and they are publishing papers and welcoming research that doesn't treat healthcare as sort of a tangential topic, but really sees the application of marketing to healthcare in improving people's lives, in improving people's health, and then also saving money not just to a hospital but to the general economic system. So we are very thankful for this opportunity.
Mm-hmm. And I'm just putting your emails back up here as well, so that if people have ideas for projects or if they want to chat with you further about what those collaborations look like, so they might get involved in these kinds of things. I think what you're describing is, to me, very important, and it is an overlooked source of opportunity for the field. And so I'm just so pleased that this is what you guys are involved in. Is there, just as we close, is there anything else that that you'd like to share about the project, or directions, or to say to this part of the field who's listening in on this webinar today?
No, we just, at least I'd like to speak on behalf of Yixing and Vikas as well, and say thank you. We are extremely grateful to share this work with listeners, and grateful to the journal, grateful to you, Chris. And also, I want to reiterate what Vikas said, which is that this is not a standalone or tangential topic in marketing. It's in fact intertwined with what marketing as a discipline is trying to do. And we just hope that, we can do more in this area and welcome others who are doing more in this area as well.
Absolutely.
Oh, wonderful. Yes, wonderful. So thank you all very, very much. We very much appreciate the insights, the work during the time when you were presenting. Actually, here's a quick question. I would urge the authors to also consider a large number of journals at the intersection of social science and medicine, health psychology, social science and medicine. I think some of you are publishing in those journals as well, and you're working with physicians on projects. But I think those are wonderful ways to get the word out about how much marketing can help solve some of these problems, and the use of and the powerful way in which data analytics can serve that need as well. Do you guys want to add anything on that before we close?
No, I think it's wonderful that all these disciplines are coming together and it's blurring the boundaries, in that sense, right?
Mm-hmm. Absolutely. I think this is the way that we can help the world because we have different skill sets, but we can attack problems jointly. And this virus is just a great reminder of that opportunity. So thank you very much, Yixing, Hari, and Vikas, and everyone can look for their paper online. And there is a more of a managerial version if you'd like to share with your staff and get them to start thinking about this. And then the paper itself is up online. So thank you all very much.
Thank you.
Thank you.
Thank you.